screening of congenital heart disease. You know, in 24 hours and 48 hours of the neonatal age and at discharge, preferably every neonate should have the congenital heart screen. And how do you do that? You auscultate the heart, you listen the murmur. You know the 22% of the neonate can have a murmur because of the aberrant sort of vascular connections and all this and that. Neonatal physiology normal, but ultimately 1% of this neonate do have congenital heart disease. To identify those neonates, apart from auscultation, we can do the pulse oximetry. Pulse oximetry on the right fingers, middle finger, and your saturation more than 95% with less than 3% limb differences. That means the neonate has no congenital cardiac illness. On the other hand, when the saturation is 90 to 94% and the limb difference is less than 3%, you have high possibility of it. When less than 90%, you have very high probability. So do this second screen, do the third screen, and when you are in suspicion, do one echo in good hand in experienced person, and then measure the BP of the limbs in the neonate, limb difference, upper, lower, right, left, coarctation of aorta, and few more other uncommon causes. So other way, the common acyanotic heart disease are the ventricular septal defect, then maybe ASD, and then a PDA, and then they present little bit late because of the higher amount of pulmonary pressure. When the pulmonary pressure settles down to its normal position, then this murmur become more apparent. So until that, you cannot diagnose a good amount of cases, visions. So if you do this screen, you will be able to diagnose these things faster. In fact, there are some of the common lesions who are to be intervened early are to be diagnosed. Suppose TGA, then it immediate intervention, surgery within 2 weeks, the arterial switch. So thereby it's essential. And other way is to see the pulmonary blood flow, pulmonary oligemia, pulmonary plethora. So normal pulmonary blood flow you can find in other less common diseases like aortic stenosis, mitral stenosis, and congenital, of course, and then your mild sort of pulmonary stenosis, and then your cyanotic heart diseases. They have less pulmonary blood flow, and they are tough. Tetralogy of Fallot, pulmonary stenosis, critical sort of pulmonary stenosis, tricuspid atresia, and your Epstein anomaly. On the other hand, increased pulmonary blood flow, X-ray evidence of the plethora is seen in the TGA, single ventricle, and hypoplastic left heart syndrome, and truncus arteriosus. So these cases are to be diagnosed in this way: pulse oximetry, murmur, their echo, and finally, when intervention is needed, to go for the cardiac catheterization. Send him or her to a specialized center or a specialized who can handle these cases well.